Welcome to the podcast series Inclusive Research and Innovation in Science, Technology, Engineering and Mathematics. Inclusive research and innovation takes place whenever science, technology, engineering and mathematics scholars actively integrate the diversity of human beings in their work. In doing so, they contribute to inclusive processes and results. Yet, how do we get there? My name is Claudia Werker and I'm an associate professor at Delft University of Technology in the Netherlands. Today I welcome my colleague, Dr. Irene Grossmann from Delft University of Technology. While inclusive healthcare has been discussed for many years, we do not seem to be there yet. Welcome, Irene. It is great having your views on how to move towards truly inclusive healthcare in the future. Please give us a short overview about your background and what you actually do as research.
I was previously an oncological surgeon, and I've done a lot of research into the staging and follow-up of bowel cancer, and that will come back later. That's why I think it is relevant to mention. 2 years ago, I came to TU Delft to work on safety in healthcare and continuing my research career. And at the same time, I'm also working as an emergency surgeon at an emergency care department at the Delft Hospital. So that's where I come from. And safety in healthcare I consider in many different aspects of the safety in healthcare, and inclusiveness and diversity is one of them.
So could you tell us what has been your major driving force to do this kind of research?
Well, then we indeed come back to the bowel cancer case. When I was doing my research in bowel cancer, I needed some data on the type of patients that I was going to study. And while doing so, I noticed that there were not a lot of data available, so I started collecting them. And then my idea was, well, if we want to really find an approach that makes sense, then we must include all the patients that come with bowel cancer in the hospital. I had some time left, so I said, okay, I'm just going to collect all patients that come into our hospital. I'm going to take their data, and then in 2-3 years' time, we will ask them to participate in a prospective study. So I did exactly that. And then after 2-3 years, or actually after 2 years, we looked at the data, and I was shocked by the difference in my data as compared to the data from trials that were conducted. And so the starting point of my cohort was so vastly different than the cohorts of trials being conducted that I started to wonder what's wrong with the trials, or what am I doing wrong? And when I looked into the data, I noticed that mainly the vulnerable patients were excluded, the elderly patients, the patients with more complex disease were all excluded. And that meant that the protocols that were developed upon these clinical trials that were conducted on a very skewed population still were used also for these categories. While these categories often were the more vulnerable patients. So at that time, I thought that's weird, because probably these treatments do not apply to them, or give too much complications, or in other ways are just not suitable for this patient group. And that worried me a lot, and that is the reason why I decided to do my research including everyone, so based upon my own cohort. And I actually wrote a chapter in my dissertation on the need for prospective data that included all patients to have a valuable and representative cohort of patients to conduct studies on. And to my surprise, it was not accepted. It was actually debated a lot because it was against the principles of evidence-based medicine, which I disagreed with, because evidence-based medicine actually acknowledges this point. So, and that was a situation where it all started, that I started to wonder, do we have the right perspective on treating patients of considering illnesses if we by default exclude relevant cohorts of patients from our studies to simplify it? And that's where it all started 15 years ago.
And I can imagine that as a PhD student, you are also at all these people who are senior and suddenly telling you what you are doing is not the right way of doing research.
Yes.
How did you manage to really go for it and say, okay, you are all telling me that this is not the way our kind of science, health science is done, but I keep doing that.
Yeah, maybe I was a bit naive, but I did my PhD on my own accord, so I was not hired to do it. That gave me some freedom. Also, my promoter and my co-promoter were very supportive of me. Even though we had a lot of debates, they still kept supporting me. And for me, it was just a no-brainer. If you have an observation that is valid and that I can actually demonstrate with actual figures, so how can you not see that? So for me, it was not an issue. I thought this is just what I see and what I notice, and this is what I'm going to report. And there was, if I can tell you a kind of a funny story also what happened when I started to use these data. I use this data for my studies, but I also use the data for quality evaluation, which was not intended at all. But I noticed that a certain type of surgery that was done had a much higher complication rate than we assume in general. So I reported this, and then my co-promoter said, I think you're right. I think we have to address this issue. So I demonstrated and I showed these outcomes of our center, which was very courageous of that center, to the Dutch surgeon group. So that was received, and then it was like, yeah, well, you're in that center and probably you're not doing it right. And, this kind of arguments. And then I said, well, I think I'm right, and we are quite a good center, so that can't be true. So I asked my promoter, who then was heading the national registry that had just started, to look up those data for me and just to compare them to our center. And to our surprise, or actually not to our surprise, but to many people's surprise, the outcomes were exactly the same. That means that these high complications rates were unobserved and unnoticed and underestimated also. And when you then look at 85-year-old vulnerable patient with anemia, that means that you have a too low blood count in the blood, then you should really reconsider doing this type of surgery. And that's also where my interest in safety began. That I noticed that our decision making was not based on the correct data. So I addressed this issue, and I got confronted with a lot of people who kept telling me that we were doing things wrong, and they were doing actually some better methods, and they were doing better surgery, so it didn't apply to them. And I discussed this also with a friend of mine who's a leading surgeon in Germany. And he said, okay, please tell this story on a conference in Germany, the Visceral Chirurgen, so the visual surgeons community. So I did so in 2013. So I demonstrated first our outcomes, which was from the local center, which was received by this audience with, oh my, this is really bad. And then I showed them, well, it's actually the case in the whole of the Netherlands, which was actually quite bad. And then I demonstrated, really look into your own outcomes, because it may be true for you as well. So I got no questions from the audience, and after me someone spoke and actually said, well, my complication rate is much, 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 much lower. And there was no criticism, no nothing from the audience, which really baffled me. And then, okay, I went away from this session and I was really thinking, what's happening here? And then people came to me in the corridors and said, well, it's the same with us, but we couldn't say it in front of everyone. So this is sensitive issues that arise from data and from knowing data and from actually realizing that you have to include everyone to really know what's going on. Even if it is confrontative, even if it's painful, you must look at all the data, and that's the only way to improve. So inclusiveness is not just a nice to have, it's a need to have to be a real professional. And it counts for studies that you conduct, like trials you conduct, but it also counts for analyzing your own data there is a large diversity in patients, in situations, and you need to know about them and take them into account. And that is not happening in healthcare at the moment. So that's why it's extremely relevant for us in the context of safety and quality of healthcare.
Right. I mean, it looks like you are doing really best practice regarding including the actual stakeholders in all their variety. Yes. I was wondering whether you are also including researchers from other disciplines to help you and who they are and what kind of background they have.
Yeah, well, that's indeed the next step, because in my research time before, of course, I only worked with doctors, and once we involved a mathematician because we included a cohort that was not in the study, namely the ones who were excluded, and we decided to include them as a third trial group with the national registry data. And the data became so complex that we had to involve a mathematician to correct for the oddities that we couldn't oversee anymore as doctors, as medical doctors. So that was actually the first time that we really drew in researchers from other disciplines. And what I'm doing right now is that I make a point out of it when I came to TU Delft is looking for knowledge in other disciplines from other researchers to look into the aspect of safety in healthcare, because it's way too much something that doctors think they can solve on their own. And I think they really miss valuable input and valuable knowledge if they do so. So next Monday, I will also try to defend this principle of collaborating with a variety of researchers and variety in background of researchers to address one and the same issue. And that's also what we do indeed with the Institute for Health System Science. We adopt exactly the same principle. You really need to build bridges between those disciplines, and you really need to collaborate on these issues and try to understand what language you speak. Because sometimes we use the same words and we need something completely different, which is sometimes hilarious. If you find out, oh, I thought you were talking about this. Well, no, I was talking about that. Oh, okay. So it's really, it's funny, it's nice, and it's really an enormous wisdom that you get from seeking those collaborations. But you must be vulnerable. You must acknowledge that you do not know some things.
I mean, you can imagine that this is music to my ears, as my research background is a collaboration between innovative agents and proximity between them. Could you perhaps give us a bit of insights into the kind of disciplines that are relevant or potentially relevant for your kind of research?
There are quite a lot, actually. I think one of the closest ones are the designers. And especially the designers who adopt the human-centered engineering, human factors designers. There are quite some descriptions of that study area, but it's the design that really counts for the economic designs that really could help healthcare. So that's one. But then we have what I explained before, the mathematicians who actually can model some complex processes going on in a much better way than the quite simplistic reductionist approach that we tend to adopt in healthcare. As I work with Katarina Stankova, who does a game theory model on cancer behavior, which I think is a really brilliant idea that no doctor ever could have thought of, because we just don't know anything about game theory or evolutionary principles, and the fact that you can actually model those mathematically. So that's extremely valuable inputs. Another one is physics. I did a semester in physics when I studied myself, when I studied medicine. And there I studied systems biology and neural networks. And what I encountered there was that I met people who knew nothing about biology. So we actually started teaching each other. So we taught the biology behind it to the physics students. And the physics students taught us how you can translate those principles of what we told them into algorithms that can simulate what was actually going on. And that opened my eyes as well. All right, so you can actually calculate and actually simulate biological principles. That opens a whole new world to healthcare. Actually, I can go on and on. Ethicists, philosophers who know about principles of science. For instance, the evidence-based movement has started out as a really good initiative with really good ideas, but the application turns out to be rather harmful. Not because the design was not good, but the way it was used. And you need philosophers to point out where things go wrong in the application of the evidence-based medicine. So those are just a few examples of how together you can get to a really higher level of knowledge.
Could you perhaps tell us where actually the evidence-based medicine actually goes wrong in particular? I mean, you were telling us a lot about that they do not include everyone, but perhaps I guess you think of responsible research and innovation principles, these participatory design, these kinds of concepts that we know, of course, from the social sciences, I would even say. So could you explain that a bit more in detail?
Yes. For instance, if you in evidence-based medicine want to conduct a study, there is a hierarchy of evidence. And in this hierarchy, it is said that if you use cohort observational studies, it's of less value than randomized controlled trials. So naturally, everyone goes for the net randomized controlled trials. Well, in randomized controlled trials, what happens is that you have to have comparable cohorts. And you have to include all patients that come to the outpatient clinic. So there is an attempt to actually correct for excluding patients that do not suit the study. But what happens next is that they have criteria for inclusion and exclusion to make those cohorts comparable and suitable to actually demonstrate a very particular principle, namely of a particular treatment works for a typical disease. So it's a very causal evaluation. And that means that you have a cohort that has been thinned out with a lot of patients that do not meet the inclusion criteria. And sometimes those inclusion criteria are based on social considerations or assumptions, like we shouldn't include females because the companies behind the trial could be held liable. So females will in the beginning often excluded. Elderly may be too vulnerable to test the medication on, so let's exclude them. So you then end up with a cohort mainly consisting of males, middle-aged males. So it's with all the good intentions. That's the painful part. With all the good intentions, so you end up with this cohort, then you test this treatment, and then you say, okay, we have a treatment, it works, and it comes to a one-size-fits-all principle. So it must work for everyone. So even in evidence-based medicine, they did counter that by saying your outcomes of your trials are only valid for the studied cohort, but in reality, it's not used like that. And that's the difference between a good design and the way it's been carried out and the consequences of it. So that's one principle. And then comes the next principle. If you study those treatments for large cohorts, and the randomized controlled trials tend to get larger and larger and larger to demonstrate certain principles. So you have 1,000 patients, and then you can demonstrate this medicine has an effect on like high blood pressure. But then you do not take into account that there's a variety in physiology of people, especially not the ones who are excluded, but also the ones who are included. It may work for 50% of the patients, and it may not work for the other 50% of patients, but still you have a positive outcome of your trial, but you still do not know to whom it applies and to whom it not applies. And there it goes wrong, mainly, for instance, in mental health. So if you take a sample size that is large enough, you can easily demonstrate the effectiveness of a medication. But if you then prove this effectiveness, it's been applied to everyone, even though it may not even work or have adverse events in 70% of the other population that's not suited to this kind of medication. So the one-size-fits-all principle can be quite harmful. And those randomized clinical trials who first included like 100 patients, then 500, then 1,000, and now sometimes thousands of patients in multi-center, multinational trials, they just demonstrate this works, so it should work for all. It comes into the guidelines, and then we start applying it. But it does not take into account that patients really are not the same. Female physiology is not the same as male physiology. Children's physiology is not the same as adult physiology. Elderly physiology, neither. And even in groups that seemingly are alike, there can be large differences. So I would argue for a different approach, which is a more personalized approach. But the personalized approach cannot be tested in a randomized controlled trial. Yes, you can by saying either each individual gets his own personal treatments or not. That you can test in a randomized trial. But then still you don't have general principles of how to apply medicine. So it's much more difficult to study personalized medicine than this approach of one size fits all. So there's not just one inclusiveness and diversity issue in medical studies. There are multiple.
Yes, I completely agree. Nevertheless, I would like to zoom into one which actually reflects on one half of the population. You were saying quite some time earlier, but I was really intrigued by that,
Yes.
that women were not included in these randomized trials because they were considered a liability. I do not even understand what the rationale is behind that, but perhaps you could give some more explanation.
Yes, it is quite simple. Females bear children, and there have been some studies in the past where medications were tested on females who turn out to be pregnant and then have birth defects. And there's been one typical example, and that means that the governing agencies have said, be careful with including women because you never know whether or not they are pregnant. So they're underrepresented in these cohorts because then you have to exclude all women below 40 or even 50. And if you fund a study, for instance, if a company funds a study and something happens, it costs you a lot of money. So that's what I mean with the liability. They do not want to take that risk.
I mean, it would be a bit more expensive, but I'm just thinking out loud. But you could, of course, either ask these women, as you do if you treat them, you get always the question, are you pregnant? You could ask them, are you pregnant? Or you could even do a pregnancy test before starting a trial. I mean, it doesn't seem to be so hard to do it.
Yeah, but it seemed at that time probably that it was just easier just to exclude them. And I think maybe there has also been a part in assumption that it cannot be that different. And I think it has been underestimated that it's really different. Like with symptoms, that's the research of Angela Maas. She'd done a lot of research into the symptoms of heart attacks amongst women. And it turned out that those symptoms are different between men and women. But before she demonstrated that, I think nobody acknowledged that it could be different. There was just no clue that perhaps they have a different presentation, maybe they have different. They feel it in a different way. How is that possible? It was just assumed that that could not be the case. So often women were turned down at the emergency cares with symptoms that were not according to the textbook because they were not recognized and had worse outcomes after heart attacks than men because they received treatment much later. And she demonstrated that in very clear examples that there really are differences and you have to take them into account. And only now that has been acknowledged. And I think this just assumption that men and women bodies are not that different, it's just does not come into minds. So that's a different aspect of how you also get problems and also demonstrate that it's not a nice to have, but a need to have.
So that basically means you also have to ask your research questions in a very, very different way. And the example you are giving, I mean, I would say at least I know about that kind of problem in the treatment of women who have a heart attack, certainly since 10, 20 years. And I read a recent study where actually people were suggesting that still women are not treated as well as men, particularly if they do not have a female doctor or a very experienced doctor, which is also something that is a kind of bias in the heads even of people.
Yes.
And that also relates to what you were saying earlier. Doctors seem to know that their outcomes are rather weak or bad, but they are trained to not officially acknowledge it, which is something that I find extremely worrisome.
Yes. Well, it's not that you're trained to look away. It is, it's not in the mindset to have a critical eye for that by nature, by education. And there are a lot of assumptions, and there's very little time. It's a pressurized job. You have a little time. You have to do this, you have to do that. So when somebody comes with these kind of issues, which would cost a lot of time to address, people tend to think, I'd rather not know. There are also a lot of people who do address these. There are a lot of doctors who observe these issues. And this is a typical example of Angela Maas, who actually saw this difference in female heart attack symptoms. But there are many other examples that have been addressed, that have been raised by several doctors. And also they find difficult hearing. And I think it has to do with the mindset and the knowledge and the way of looking at science in the medical studies. And I think that needs to change. I think we need a much more varied approach, that we need much more knowledge from other disciplines in the medical studies to actually have a better judgment of these issues, such as why is there a variety in outcomes between the different patients? How do I look at data? How do I interpret data? I think it is essential that also medical doctors get into that kind of knowledge and not are just bombarded with evidence-based principles that, as said, are meant well, but work out the wrong way.
Would you perhaps, because that comes to mind, of course, if you say you have such a varied population you want to follow up on, and you have, of course, then also varied data, how would big data, so data in large quantities, but also in an unstructured way that you have to work on to make it happen, how could that help? Did you consider that?
Yeah, I do. And there I lack the true knowledge of how we could deal with it. If I look at real big data, I'm really worried because I do not trust big data to be unbiased. I think those are biased as well. And that's what we saw in the AI discussion in healthcare, that they say we use big data or we use large databases. Well, I built my own database and I collected those data, and one of the things I observed is that it is quite difficult to actually have the correct data that actually are meaningful. So I spent a lot of time on the quality of the data inputs, and I excluded a lot of noise. Big data doesn't do that. So I'm skeptical about big data. On the other hand, I must also admit that if you have a real chaotic, messy big data, there may be signals in it nobody can hide. And it's in that sense, it is unbiased. Maybe you can find some clues in it that you can later validate. I'm not really sure because I'm truly not a data scientist. So with these type of issues, I tend to go to someone who really knows about it. And there are a lot at the faculty, so that's a good thing. But I'm worried, I'm skeptical. That's my approach, but I do not exclude these type of approaches. But I'm, especially in healthcare, the data sources are very skewed. Maybe some population studies are better, like the population screening studies. They may have rather good data, but a lot of other data, they're really unreliable.
Okay, I see. Could you perhaps tell us what is your vision on what would be the coolest kind of result that you could achieve in your line of work? When would you be absolutely happy?
Wow. Yeah, that's a very good question. Yeah, my goal is to improve safety in healthcare, and I'm very much into actually really knowing what we do as doctors. So one of our principles is do no further harm. And I think that principle is so incredibly valuable, so valid. And in order to know what we do is actually the right thing to do, we need knowledge, a lot of knowledge. We need data on what the outcomes are of what we do. We need to be able to interpret those correctly. We need to know how to apply them correctly. We need to be skilled in being very critical of the information that we get and how we apply them. And we really need to know whether what we do actually fits the person in front of us. So in the end, it is the outpatient clinic room where there's an individual with a multiple of conditions. And you as a doctor must understand the art of deciding what is the best for this individual patient. And you need this background of knowledge and data and knowing how the population looks like, but you also need to be able to decide for this particular patient what to do. And there you must acknowledge the diversity in the patients and also think in their interest and no other interest at all. I think that's the art of medicine. And so if we would approximate that, I would be extremely happy.
So correct me if I'm summarizing it wrongly. You would like to have treatments where you are sure as a medical doctor that you certainly do not do any other harm. Mm-hmm. And perhaps you do not know whether it helps, but at least you're sure that it does not do any harm.
Yes, but also it must help, because any treatment that is given that does not have any beneficial effects can do harm. Even if it's just a cast. A cast is when you have a broken arm. Nothing we do is harmless. So fitting the right treatment with the right person, personalized medicine, based on knowledge and explainable data, I think that is the key.
I understand. If you have to point to one aspect that is hindering you to achieve that, what would that be?
The understanding in the medical community that these things matter. And I know where it comes from, and I think we have to change that, and that is in education.
You were mentioning education before. Of course, we are both working in education, so we can work on that as well. But it is, of course, something you need to know first in your discipline, how this all works before you can actually translate that into teaching. So it's a kind of double game, a kind of double end game you are after.
Yes. And I think you can do that on the go. And that means there's research going on, you put it into education, but you can also explicitly mention where there are uncertainties and gaps of knowledge. And if you do that, you can already start doing education, but be completely transparent about your uncertainties in your theorizing. So that means a humble approach as a researcher, and that is not always appreciated. But I think we're getting there.
Given our conversation, is there anything you would like to share with us that you did not have the chance to do before?
No, I think it's extremely good development that at our faculty we chose to have a focus on health and care, because I think that our faculty is really capable of providing knowledge that could help health and care getting much, much better. And that counts for personalized medicine, that counts for organizing care, that counts for the role of prevention in our health conditions. And we've been given the opportunity to do exactly that with the new institute that we established. And I think there's an enormous potential in transferring this knowledge from one to the other domain. And I'm really, really happy that TU Delft has given us this opportunity to do so.
Thank you once again for contributing to our podcast series on inclusive research and innovation in science, technology, engineering, and mathematics.